It's a great pleasure to be here in Tokyo, and I would really like to congratulate JSTAR for having run 4 waves of data. I remember when it started, and it was not clear whether there will be a second wave and a third wave, and now we have 4. So that's really a great achievement. And I would particularly like to congratulate Hide Ishimura-san, who's actually my MIT brother, right? And Satoshi, who has done much of the footwork. And it was quite a lot of work and a lot by foot, indeed. What I want to show you is the a little bit what research findings SHARE has produced, and to follow a little bit like the outline of Hide in shortly presenting what SHARE is. And my stress will be SHARE is a little bit different from HRS and JSTAR because it actually has a lot of countries. So it's not a one-country study, but a many-country study. Then show you how useful SHARE is actually in analyzing policy, give you quite a bit of examples, and finally dig a little bit deeper in 3 examples where you see really the power of this kind of data like HRS, JSTAR, and SHARE. Okay? So the specific thing about SHARE is it's actually by now 21 countries, quite a bit, all across Europe, including Israel, and you see there's still some empty countries where SHARE is not taking place, but largely all countries in Europe are covered. SHARE is tightly connected with HRS, with JSTAR, of course, here in Japan. And there are now also 2 surveys in Latin America, which so this is the great family of what we call the HRS type study. The point I want to make is that SHARE is especially designed to look at the at economic policies. And that's one reason why we look at different countries. Europe has many different kind of policies in place. France, very different kind of policies, for example, than Germany. The Mediterranean countries are different from the Scandinavian countries. So you actually learn a lot by comparing these different policies across European populations. So this is what makes SHARE so special. The methodology of collecting the data is actually, if you look at each country separately, very similar to HRS and JSTAR. So we go to the households, collect health data, socioeconomic data, and social participation data. Pretty much the same list as you have seen from Hide earlier. The main design challenge in SHARE is that it's different countries, and that opens up a new world. There are different kind of institutions, there are different kind of languages, there are different interpretations of the words, even if you literally translate things. So it's much harder to actually run a survey across 21 countries than in a single country. It's a very complex organization. We have sort of the management is distributed over 5 places. But then in each country, we have a country team. And then each country has a survey agency running about 2,000 interviewers across Europe. So it's a complex enterprise. And there's a reason why these PIs slowly get gray hair, I think. Now, we try to harness this complexity by a lot of electronic tools. Language is, everything is captured in computer programs. In addition, we try to measure things as objective as possible. So whenever we avoid asking people, how healthy are you, we rather go take grip strength, for example, like in JSTAR, or take blood and actually look at the components in blood. And it makes a big difference because in some countries in Europe, health is overrated, and in other countries it's underrated. The Danish are well known for being very optimistic about their health, and the Germans, like me, are always very pessimistic and are close to dying when they have a cold like me. Okay. So let me show you how powerful this kind of data can be. And I do this in giving you an overview of papers. You see now a set of titles of papers, and I make quick remarks on those papers. These are selected new publications in the recent year. So one paper, for example, looks at the balance between public mandatory health insurance and voluntary private insurance. Do they crowd out each other? Do they strengthen each other? That's an important question also for Japan. The next paper shows at the scarring effects of unemployment. So particularly in young years, when people are unemployed, you actually see the health effects much later, 10, 20 years later. Actually, and you see that the scarring effects are harsher in those countries which have less unemployment insurance than in those countries who have unemployment insurance. So you see the beneficial effects of social policies here. There's a lot written on the life course variables. Share as one feature really does not only look at the current state of the people, but also ask how they grew up and as retrospectively how their lives have been. And you learn a lot about this. Obviously, a lot of research is done on retirement. And again, you have seen the work just presented by Ishimura-san on retirement and how it may change if laws will be changed in Japan. Now here, I picked 3 papers because they put retirement in a completely different context. And that is something which is very new. In the labor force participation, in the kind of typical labor force surveys, you have economic variables and that's about it. But the interesting thing about retirement is that it's much more complex. It really depends on health, of course, but also the social environment, the work environment. So we actually collect a lot of data which are not the classic kind of economic data. So you see some applications. The first paper essentially tells you how important it is to have a nice work environment. So the psychosocial environment in a workplace is very important. Those people who actually like to go to work do retire later, as opposed to those who hate their work. Social policy actually takes has an indirect influence on retirees. For example, you see that in countries which have maternity benefits, women retire later than if not. I have done some work, and I will actually present it a little bit later, where I look at the effect of retirement on the number of friends you have, and you find some surprising findings. A very funny paper, which I like to quote, which actually appeared in the AER, sort of our flagship journal, shows the effect of language on economic behavior. In Europe, you have all these different languages. By the way, share alone is being presented in 27 different languages. And some of these languages have a future, and others only a present. And these people have different savings behavior. At least that is what the author claims. It's quite an interesting paper and a funny paper on top of it. Finally, a lot of work has been done on family social networks. And I think the aspect here, which may be interesting for Japan, is you have seen quite a change in family structures as the European countries have aged. And I think those developments are even more pronounced in Japan. because you have two developments, the aging of the populations, but also the change in family structures which coincide, where less dependence of the older generation is on the younger generation. So it actually would be quite interesting to have joint papers here between the JSTAR data and the SHARE data. Let me dig a little bit deeper in three examples, and actually sort of take a specific point here. These SHARE data, and I'm absolutely sure the same will happen for the JSTAR data, is actually has refuted quite a few prejudices. One of the prejudices, which were widespread in Europe, is that health declines dramatically after age 60. So there's no way those poor French people could ever work till 65, or the Germans till 67. Well, if you look in the data, indeed, what you see, however you want to measure it, the blue one is self-rated health. Then the next one, the green one, is functional health. What can you do? And the red one is objective health measured as grip strength. You do see a decline, but look how slow it goes, and very smoothly. So there's no sudden drop at some natural retirement age. It just doesn't exist. It's pretty flat between 60 and 69. Now, what is even more interesting is if you look at the grip strength, the red bars, I put the error. This is 2 standard deviations up and down. So this is sort of the spread of the data in each year. So the spread for the 60-year-olds, the spread for the 61-year-olds, and so forth. And you see that the spread is much, much larger in any given age than the change between 60 and 69. So it's more the heterogeneity which should worry us if we talk about later retirement ages, than the fact that health is slowly declining. Now, let me just point out 2 points here. One, let me just go down here. If you compare the healthiest at age 69, then they are much healthier than those who are 10 years younger, but at the lower health part of the population. So what should us worry is those people who are at poor health or their age, vis-a-vis the very healthy people, but not so much that health declines. And again, the SHARE data is showing very systematically what the problems could be. Here are, excuse me, here is the log odds of having one of these diseases, cardiovascular diseases, stroke, diabetes, lung illnesses, other cancers, for men and for women, and it's the higher prevalence among those who have less education than relative to the people who have more education. So I split the sample in the better educated half and the less educated half, and you see that there's a huge difference, and the difference is particularly pronounced in diabetes and in lung illnesses. Now, what is specific about diabetes, what is specific about lung illnesses, particularly lung cancer, it's behavior. So you see that diabetes and stroke, by the way, is 60% more prevalent among less educated women, and 90% more prevalent among less educated men. And it has a lot to do with health behavior, with nutrition behavior, with smoking behavior, which again has socioeconomic roots if you dig one level deeper. So it's a nice example where you can really go down complicated pathways from seeing differences in retirement behavior, differences in health, differences in behavior, differences in socioeconomic status. And this kind of data which captures socioeconomics as well as biomedical data, like JSTAR, like HRS, like SHARE, allows you to do these kind of analyses. One additional point, another colorful graph here. Some people claim that it doesn't really matter how much you spend on health for a country. That's certainly not true. If you measure health correctly, and you see we measure it in an objective way, then you see that there's a positive correlation between how healthy the countries are and how much you spend on as part of GDP. Switzerland spends a lot on healthcare, and it's the healthiest country in Europe. Spain spends very little on healthcare, and it's the least healthy country. In addition, there's a lot of variation. Let's just take this where I made the blue rectangle. You see that there are countries who have the same health outcome, but spend different amounts. So this I would call efficiency of the healthcare system. And you see that Germany, unfortunately, has much lower efficiency than the Scandinavian country or Austria, which is surprising because Austria and Germany are very close neighbors and have many similarities. Okay. The second example for a prejudice is, again, which is widespread in Europe, is that retirement is bliss. The best which can happen to you is to retire as early as you can and then live happily onwards. Well, what I put here on the axis is the average cognitive score. This is exactly what HURD has described. It's the word recall, where you have to use your memory capabilities. And lo and behold, what you find is that in those countries where people retire early, people remember less. And in those countries where you retire later, you actually remember more. That's a finding which has been found by a group of Belgian econometricians, and this is a very nice kind of analysis by two Americans. Now, the question is, of course, is there something real behind it, or is this just a spurious kind of correlation? Now, what is obvious is that as an employer, you really want to get rid of those people who cannot remember anything anymore. So there's certainly one way of correlation which goes from low memory capability to being employed or not. But the interesting thing is there's also the reverse causation. And that is what we are after. And looking a little bit closer, let me actually jump over this. A related finding is that the same happens with the number of friends. If you look at the number of friends, you also find a correlation with memory capability. The more friends you have, the better your memory ability is, and vice versa. And again, it's hard to understand in which direction the causality goes. Now, so to really tease apart what is cause and what is effect, it again helps to be international. And that is the main point I want to make here. If you have international variation, when you actually are allowed to retire, then you can concentrate on one direction of causality. If you have a pension reform where from more or less 1 year to the other, you change the retirement age, and then you see that the memory ability declines if you reduce the retirement age, and it goes up when you increase the retirement age, well, then you obviously have learned something about the causal direction in one way. And this is what you can do if you do econometrics. To make a long story short, what you learn is that about that there are various mechanisms in what makes retirement maybe something which is harmful for your brain is first, and this is the biggest effect, 64%, if you don't use your brains on the job, well, you're likely to use your brains and you lose your memory ability. But you also, and this is the second most important thing, you actually lose your friends and your colleagues quicker, probably sit more isolated on the TV screen, do the entire day nothing but watch the TV, and that does not seem to have a helpful effect on your brain either. You should think twice before retiring too early because it may do damage to your memory capabilities. Actually, if you do this with other cognitive measures, you find similar results. It's not only memory, but other kind of mental health dimensions. The third prejudice, which is something which has made the news both in the United States but also in Europe, is that there will be a war between generations. I know too little about Japan, but in Germany you had a three-part, almost a soap opera in television, which told the horrible story of really war between the young and the old. The young wanted to have more money from the elderly, who gobbled up all the pension expenditures. And finally, and similar kind of stories and movie tales have been told in the United States. Well, if you actually look what happens in Europe, you see a lot of intergenerational exchange. And this is what this first graph shows. And something which may be interesting, you see more generational exchange if you just measure how many couples of parents and kids interact with each other in the north than in the south. So the Scandinavians actually have a lot of interaction with their children. If you actually measure it in hours, it flips. And you see that particularly in Greece and in Italy, there are many more hours spent together than in the north. So it's a funny kind of pattern between the north and the south, but there's a lot of change if you look at these the absolute numbers. Another finding which is interesting is if you on one axis, on the horizontal axis, put state activity, like social expenditures, social services, expenditures for families, and so forth. And on the vertical axis, family interchange, then some people have claimed that there will be crowding out. The more the state invests in families, the less the family will actually care about itself. That is not true. You actually see the opposite. The correlation is almost always positive and significant. So we actually rather see a crowding in, that if there's a, let me phrase it this way, a caring state, the family also cares more. That was a surprising finding because in some sense it counteracts economic intuition. The third one is, again, based on share data, a little bit complicated. You see two maps here. One map, the right one, the big one, shows countries and regions. It's actually made by region, where conflicts with children are widespread. And you find here that particularly in south of Germany, Austria, Switzerland, and Italy, there's a lot of conflict between children. If you try to correlate this with how old these regions are, that is the little map on the left-hand side, well, you don't really see a correlation. Okay? In some countries, in some regions, they are old, dark on the left, and you also see that there's a lot of conflict, but you also see exactly the opposite, for example, in the north. Now, you can do this with many kind of dimensions. For example, this is conflict with parents. Now, just upside down. Now we ask the children whether they have conflicts with their parents rather than the other way around. By the way, those two things do not match, which is an interesting finding in itself. And again, you have a hard time finding a correlation here. If you do this more systematically, you actually run regressions. Here you see 22 different dimensions of family interactions and social cohesion, intergenerational cohesion. If you count those where you find the expected war between generation, these are the yeses, where they are actually in the minority. More often you see the reverse, that in those countries which are older, cohesion is actually stronger. If you count particularly if you count the significant results, it's more opposite than the other way around. So that's actually a good message. You do not see in these, some people call them old Europe, ailing Europe, you do not see this war between generations. Okay, let me finish and summarize. This HRS-type data, JSTAR, HRS itself, share, are really an enormous help to better understand aging and also the subtleties of what could happen if aging proceeds over the next decades, like in Japan and in Europe. Now, SHARE is particularly helpful in the respect that you have variation in policies. So you don't really have to go back into history and see changes in policies. You actually have different policies in place if you compare the North and the South and the more conservative countries and the more liberal countries. So that helps a lot in identifying causal pathways to distinguish in which direction the causality goes. And it helps to refute prejudices. And I think that's very important because there's so many prejudices about population aging. One prejudice is that health is bad in old age. Just not right. That healthcare is, you should not spend so much in healthcare, rather do cost cutting in healthcare. Well, only to a limited degree that is right. Retirement is certainly not bliss. There are negative side effects. And the last one, which I showed, is that that there's an intergenerational conflict coming up is really a myth. So I think if you can show these kind of things already within Europe, there should be many more papers written which use the entire variation of policy around the globe together with HRS data and particularly JSTAR data. And I'm looking forward to those papers to be written. Thank you.
Good afternoon. Thank you for inviting me. I always enjoy coming to Japan, if for no other reason than the delicious food. I will talk a little bit about the health and retirement study. If you're following in the notes, you will find that the first few slides are not included, but then you'll be able to pick it up because I added these slides this morning. Let's see, the advance here is. Okay. To review HRS, it's been interviewing since 1992, around 20,000 people over the age of 50 every 2 years. And every 6 years, we add a refresher sample as, of course, after 6 years, the initial people age 51 are now age 57. And to keep the sample representative of the population, we add more people. It's a survey of both husbands and wives, even if the wife or husband is not age eligible. We collect a large range of data of the types that you've seen discussed here. HRS was a model for similar data collections on international data collections that we've heard about here. And here's a list, and even more are in progress, for example, Northern Ireland and others. My talk will be about a specific aspect of HRS data that comes from being able to observe people over a very long period of time. And its really objective is to show the usefulness of very rich data in a long panel gathering program to show how it can be used to understand what happens in older age and to address policy problems. So it's kind of an example, a detailed example of what you can do if you gather such data. This is the title. It's taken from a paper, The Lifetime Risk of Nursing Home Use and Lifetime Out-of-Pocket Spending. And this is joint work with Pierre-Carl Michaud and Suzanne Roveter. Well, first, aging of the population. This is the percent of the population age 65 or older. If we go back to 1970, we see that the green line, which later is at the top of the graph, Japan actually had the lowest fraction of the population 65 or older, around 6% or 7%. By 2050, Some years in the future, that's projected to be approaching 40%, around 38%. The oldest population of the ones listed here, the pink line is 31 European countries, the yellow line is Canada, and then the lowest line is the US. The US has benefited in this regard from a higher total fertility rate as well as higher levels of immigration. Well, if you kind of think about how society is going to be different when 7% of the population is age 65 or over compared to 38%, it must be substantially different in many, many aspects. And one aspect, before I go on to that, some of this aging is due to baby boom. Some of it is permanent and some is increases in longevity. And I put quotes around some of this because some of this, in fact, may not be permanent, and some of it is far from temporary. The baby boom cohorts are those cohorts who were born between 1946 and 1964, very large cohorts in the United States and somewhat elevated cohorts in other countries. And those cohorts are now reaching age 65 and passing into old age. And as they move through old age, they will create a bump up in the fractions of the population at old age. I put the temporary in quotes because it's true, it's temporary in some sense, but it's actually going to take a very long time before the baby boom finally ages out of the populations. A permanent reduction in fertility rate, well, maybe it's permanent and maybe it's not. Fertility rates go up and down. Certainly it was a surprise when they went down following at the end of the baby boom, and perhaps they'll go up again. In my view, they're substantially dependent on economic conditions. For example, the US fertility rate, which had been a little bit above 2, I read the other day, is now down to 1.88. That is today, and most people think that is due to the Great Recession and the decline in wages and economic circumstances that accompanied that. So possibly the fertility rate decline is permanent, but possibly not. And then finally, the permanent increase in longevity. We have enjoyed increases in longevity in the United States. Part of that has been the result of the cessation of smoking that began following the Surgeon General's report in 1964. But if you look at self-rated health in the HRS of the new cohorts, that self-rated health is actually declining. It appears that people who are in their early 50s rate themselves as having worse health. The rising levels of diabetes, rising levels of ADL limitations in those younger populations, and declining levels of self-perceived life expectancy. So it's by no means clear to me that this increase in longevity is going to persist. If that does not persist, then these population projections will be inaccurate. One reason this is extremely important to understand the oldest old population is the issue of dementia, which has now become a very active area of policy concern, not only in the US, but worldwide, I would say. And this shows the prevalence of dementia at age 71 to 74. It's around 2.5 or 3% of that people who are in that age band. Approximately every 5 years of age, that prevalence doubles, reaching around 38% among those 90 or above. There's some international variation in rates of dementia, but more or less this kind of doubling with 5-year age bands is correct. And the implication of that is that with the aging of the populations, particularly at advanced old ages, society will have many, many more cases of dementia that it will have to manage and deal with and pay for. Total long-term costs of care, total cost of long-term care, and by long-term care I mean nursing homes and care in the household, will increase. The distribution of those costs depends upon how the Social insurance, it varies from country to country, or universal insurance, and whether people are expected to cover these costs out of pocket. The U.S. Has nursing home insurance, but nursing homes are very expensive, around $85,000 per year, posing a major financial risk to households because social insurance is of limited value, which I'll explain now, in a moment, I should say. We would like to know, in the U.S. and in other countries, what are the risks facing individuals of using nursing homes as they age? That is, we would like to know longitudinally for a particular person, what are the chances somebody will end up in a nursing home, and what out-of-pocket spending somebody may face, as well as other research questions we would like to know. But the focus of what I'm going to talk about today is the distributional aspects for a particular household that is integrated over its expected lifetime. We can look at these same things in cross-section, but that's quite a different research question and much easier to answer. We need a very long longitudinal study like the HRS in order to answer questions of lifetime risk for a particular individual or a particular household. So we'll use the HRS to answer these kinds of questions. Nursing home use is likely to be the same in other European countries and as it is in the US and Japan. I don't know enough about social structure here to be able to comment on this. Among people who are severely demented, that is, with advanced case of Alzheimer's, nursing home residence is really required, and so some of these patterns will be similar in Japan as in the US. But of course, out-of-pocket spending will depend upon the national institutions. In the US, we have medical insurance. Medicare is called Medicare. It's almost universal for the population 65 or over, but it only pays for short-term hospitalizations. It does not pay for extended stays in nursing homes, and it requires co-pays. A second program called Medicaid does pay for long-term care in nursing homes as well as long-term care at home, but it's means tested. People who have sufficient assets do not qualify for Medicaid and will have to pay for nursing homes out of pocket unless they happen to have long-term care insurance. So although there is insurance for long-term care, being means tested, it means that to use that insurance, one must become impoverished or at least have low levels of assets, and that makes that insurance unattractive for some people. There is private long-term care insurance, but it's only about 13% of the population age 65 and above has such insurance, and it's become less and less attractive as large insurance companies have found they've been losing money on this insurance policies, I think partly because they've underestimated the risk of using nursing homes. There are estimates of lifetime nursing home use in the literature. Let's skip to the bottom of this slide. There's a U.S. government website, longtermcare.gov, that gives an estimate that the lifetime risk of a 65-year-old in the United States being in a nursing home sometime in his or her remaining life is 35%. So about 1/3, according to this website, of people will be in a nursing home at some time during their remaining lives, and we will find that percentage is much, much higher. Our contribution will be to use much better data than people have had in the past. We will estimate this both parametrically and non-parametrically, and our main result is that the risk is very much higher. We'll see it's in the 50% rather than the 35%. And also the risk of a substantial stay that is more than 100 days is quite high also. Well, so we'll use data from the HRS. You can skip most of these points. If you go down to number 7, at baseline, the HRS sampled from the community, that it does not sample from nursing homes, and we have to take that into account in our work. I'll explain how we do that. And HRS follows everybody, whether they are in the community or whether they're in a nursing home. The implication of that is that if we wait long enough, everybody who will be in a nursing home will have entered a nursing home, and we will be able to sample people and interview people in nursing homes. HRS also has proxy interviews. If people are unable to be interviewed themselves, HRS interviews an informant. It has exit interviews. These are interviews that are made after somebody's death, and we find out a lot about nursing home use in the time period between their last interview and the time when they died, and also ascertainment of vital status. And as I say, we follow the same people for up to 18 years. These give names for some of the cohorts included in the HRS. We are going to use just the AHEAD and the HRS cohorts that are highlighted here. The AHEAD cohort was age 70 or over at initial interview, and they've been followed since 1993. The HRS cohort was age 51 to 61 in 1992 when they were initially interviewed, and they've been followed now since 1992, and we're continuing to interview that cohort. And you can see the total ends we're looking at, if you add the two together, something like 18,000 people that we'll base this on. I'm going to skip this. Well, so I mentioned an important issue is that both HRS and the AHEAD were conducted in the community at an initial interview, and but to capture short-term stays, so that's one issue. We need to capture short-term stays, we need the proxy responses, and we need the exit interviews. We have all of those things in the HRS, and a couple of them I'll show what difference those things make. The first is the non-institutionalized aspect of the HRS at baseline, no representation of nursing home residents at all. Well, obviously, if we're going to study nursing home use, this would be a useless data set if that persisted each wave, but HRS follows everybody into nursing homes, and the question is, after how many waves do we have good representation of the nursing home population? And this gives a graph that gives our take on this issue. This shows in the AHEAD population, age 70 and above, the fraction of respondents in nursing home at interview. And it's hard to see, but at the very bottom, creeping along the bottom at 0 is the fraction at wave 1, and that is in fact 0 because the HRS did not interview anybody in a nursing home at wave 1. But wave 2 is the red line, and you can see already a number of people were interviewed in a nursing home. That is, they moved into a nursing home between wave 1 and wave 2. And you can see, for example, among the people who were 90 and above, it certainly was not a trivial fraction, approaching 20% of the population that was living in the community at wave 1 was found living in a nursing home at wave 2. By wave 3, among those 90 and above, that fraction had risen to 25%. And so the green line is what fraction at all ages was resident in a nursing home at wave 3. And you can see that compared to the other spider-like lines, which is the fraction in nursing homes at other waves, wave 3 pretty much has the same fraction as future waves of HRS. And so we took it to be that by wave 3, the population in the nursing home, in nursing homes had stabilized. And so we will use data from wave 3 onward to capture the nursing home population. In the interview, we capture short-term stays because we ask people if they had stays between the prior interview and the present interview, and if so, the total number of nursing home stays and nights. And so this shows you in cross-section nursing home use. The purple bars are the fraction of the age-specific population in the nursing home at the interview, and the red bars are the fraction of the population, age population, that had any nursing home use between interviews. And you can see that nursing home use is firstly increasing very substantially in age. At age less than 55, there's practically no nursing home use. This would, of course, be mostly for short-term stays following an acute event. For example, if somebody has a heart attack, they may go to a nursing home following a discharge from a hospital. But by age 95, more than half the respondents had had a nursing home use between the previous wave and the current wave. So very prevalent use of nursing homes. Exit interviews, if somebody has died between waves, an informant is asked to basically complete the questionnaire. And since nursing home use is very common just prior to death, if we miss that kind of nursing home use, we'll underestimate. And this graph shows you the amount of underestimation. The kind of mauve line is for the core only, that is not including the exit interviews, and the red line includes the exit interviews. And you can see, for example, at age 95 and above, about half the people you would think half the people had nursing home use, not using the exit interviews, and if you use them, it's around 58%. So we want to then look at all the waves at an individual level and find out the distribution of lifetime nursing home use. Ideally, we could do that if we followed a cohort from, say, their 50s and clear until that cohort had died and simply record their nursing home use. There would be no model involved, no estimation, just simply keeping track of the numbers. Well, we can't even do that with the HRS because we observe them for a long time, but not throughout their entire lifetimes. And so we have left censoring. That is, those who were older at baseline, for example, the HEAD population, they had some nursing home use before we saw them. And right censoring, the younger population, the HRS cohort, for example, they had no nursing home use prior to when we saw them, but they will have had nursing home use if they survive past the oldest wave where we see them. So they have right censoring. And so what we do is link these cohorts together. The center cohort is the HEAD people who were interviewed in 1998 up through 2010. They were age 75 and above. And they're linked to the HRS cohort to fill in the ages prior to age 75. And they're linked to another HEAD cohort, the 1911 cohort, to fill in the ages 87 to 99. So we use other cohorts to adjust for left censoring and right censoring. And we link them at the individual level, depending upon their position in the distribution of out-of-pocket spending, so as to maintain persistence in spending that we know is there. So this is kind of like a very high-order Markov process, but it uses the entire distribution of healthcare spending to link people together. And when we do that, we find, this is non-parametric estimation, we find that the lifetime risk from age 56 of any nursing home stay is around 56%. You may recall the number that's on longtermcare.gov was around 35%. So very, very much higher, 20 percentage points higher risk than what people have been advised before and what prior estimations had produced. Still a small amount of left censoring, but really not much more to that. We also conducted a model-based estimation based upon a second-order Markov transition model. I won't go through the details of that, but let me just go to the simulations that result from that. And from those simulations, we get a number of 57.7% versus 56% from the non-parametric. So both the model-based simulations and the non-parametric are very, very consistent with each other. One thing we can do from the model-based estimations, though, well, before I get to that, this is the distribution of number of nights as well as the risk of being in a nursing home throughout lifetime. And the mean, both from parametric and non-parametric, is, in my view, quite high. For the non-parametric, 283 nights is the average number of nights somebody at age 56 can expect to be in a nursing home during his or her lifetime. And mind you, this takes into account the fact that people who die early will spend very little of their lifetimes in nursing homes to spend a lot of time in a nursing home. In our data requires that people survive to a fairly advanced age. But that's the expected value, taking into account the competing risk of dying early before people are in nursing homes. And if you look at the distribution of that, the median, that's P50, is just 12 nights or 14 nights, depending upon what you're looking at. But if you get up to the P95, that is the 95th percentile, 1,500 nights. So that's like 5 years, according to the non-parametric, and the parametrics is somewhat less than that. So our estimates produce a very skewed distribution of number of nights in nursing homes. You can also look at this by some characteristics. Women are much more likely to be in nursing homes because they survive to greater ages than men. Why that? People who are less educated will likely spend less nights in nursing homes simply because they die earlier. And people who smoke are less likely to be in a nursing home because they die earlier, and so on. Well, that's nursing home risk. We also wanted to estimate the lifetime nursing home out-of-pocket spending on nursing homes, get the population average and its distribution. We used the same methods, but we added in out-of-pocket spending, which we record in the HRS, and we asked people if they had nursing home use, whether it was completely covered by insurance, mostly covered or only partially covered, and if not completely covered, how much they spent out of pocket. I won't go into the details of it, but we compared this with outside data, and we find that on average, these reports are quite accurate. Those are the validations. And we will find that although out-of-pocket spending is quite high at the high end, there's a very skewed distribution with a lot of people paying almost nothing out of pocket. And you can see the reason for this. At younger ages, say 70 to 71, about 70% of nursing home spending is completely covered by insurance. And in the US population at that age, it would be mostly by Medicare for short-term stays. That percent declines at older ages because the nursing home use becomes long-term care, which is then covered by Medicaid if it's covered at all, but more likely by out-of-pocket. And you can see the fraction covered not at all increases from in the single digits at age 70 to 71 to over 20% if people had survived to advanced old age. This shows the 2-year out-of-pocket spending that we would observe in cross-section, very sharply rising with age. If people who are among the, at age 95 and above, average out-of-pocket spending on nursing home costs is over $10,000. Most people don't survive to that advanced old age to experience that cost, but if they do, they will, according to these data, face very high out-of-pocket spending costs. Again, we have the same problems that we did before with nursing home use, and we solved that to get the non-parametric estimations for out-of-pocket spending discounted to age 57. So the perspective here is people at age 57 looking over the rest of their lifetimes under our assumptions. What on average will they spend out of pocket? If we use a discount rate of 3%, this is all in real, the mean out-of-pocket spending would be around $7,500. Probably a 0% discount rate is more reasonable, and there the number rises to 18,000, which is starting to become a significant number. You can see, however, that the p-value, p50 value, the median is 0, because firstly, not everyone has nursing home use, and even if they do, often people are completely covered by insurance. At the P95 level, the 95th percentile, 0% discounting, more than $100,000 out of pocket is spent. Model-based estimation, I won't go over the details of that again, but let me just make the comparison with the parametric and non-parametric. Again, the mean on non-parametric, this is 0% discounting, 18,000, and on the model-based, 13,000. So they're really in fairly close agreement. And I'll skip this part because I want to get to long-term stays. We can also estimate the fraction of people that will have a stay of more than 100 days, which is what we define to be a long-term stay. And we do that because after 100 days, Medicare does not pay anything for such stays. That all has to be paid out of pocket or by insurance. And we do the same methods that we did before. And we find out that around 27% of people aged 56 can expect to have a long-term stay. About a little more than 1/4 of people can expect to be in a nursing home for more than 100 days. And 7% of people can expect to have 2 or more stays of longer than 100 days. And another 2.4% have 3 or more. Women have much greater risk of a long stay simply because they survive longer and live a substantial amount of time in widowhood. They don't have a spouse to take care of them and keep them out of nursing homes the way that men do. Our conclusions: 2 very different estimation methods. Lifetime risk of nursing home use in the United States between 56 and 58%. Large fraction of nursing home cost is not paid out of pocket, even in the US. The lifetime costs are not high in average if we use discounting of 3%. Discounting of 0 is higher, but for couples, it's twice that amount and becomes $36,000, which is now starting to be a substantial amount. But because the distribution is so skewed, it does seem like there would be room here for insurance or social insurance. But the most frequent situations make the insurance unattractive, at least as it is in the US. The most frequent situation is the husband becomes disabled. The wife cares for him in the community. Following widowing, she lives independently, eventually enters a nursing home, spends down to become eligible for Medicaid, and so Medicaid is a better choice than buying long-term care insurance itself. Thank you for your attention.
Good afternoon. It's a great pleasure to be here in Tokyo to report on some of the research that's been done using the China Health and Retirement Longitudinal Study, which is a relatively new JSTAR type study being done throughout China. And I've been working on the project since the beginning. I can. Sorry.
Just point.
Oh, use this. Okay, thank you. The Chinese government is now paying a great deal of attention to problems facing the elderly. This is a picture and headline that came from a Science magazine article on the Charles Survey, reporting that nearly 1/4 of China's elderly live in poverty. China, as you can see, is just at the launching point of a rapid surge in aging. If you look forward to 2050, by that time, over a third of the population will be over age 60, and about nearly 10% will be over age 80. As has been mentioned previously, the Charles survey is one of a global family of HRS-type surveys. This is from a presentation by Jim Smith at RAND that he gave earlier at an event we organized in Hong Kong. And in Asia, there are now quite a few HRS-type studies. We are the youngest, other than India, which is just going on now. We've finished one national baseline and as well as one follow-up survey. And it's really following the HRS style of following respondents every other year, and including physical health exams in the baseline wave. So just a brief history of the development of the project in China. We did a pilot survey in 2 provinces, a rich province and a poor province, in 2008, and then did a national baseline survey in 2011. That survey included about 18,000 respondents. And then we did a national baseline survey in 2013, and the data from that survey will be publicly released soon, hopefully. And this year, we have gone and done a survey between the normal survey years to collect life history information on all of the respondents in the survey. So our survey is nationally representative. It's based on a sampling frame where we select 150 counties, then 450 villages or urban communities, and then we make maps of neighborhoods that are selected, and then sample dwellings, search for the eligible households, meaning households that have at least one household member aged 45 and older, and then we randomly sample one of those older persons and also survey their spouse. And so the sample for the baseline is about 10,000 households, and this is also the sample we've just followed last year with a pretty good success rate. Actually, our response rate matches the HRS original wave, 80% in the baseline, and the follow-up rate in terms of the number of people who were sampled in baseline who were found the next wave is close to 90%. And here is just a picture of the counties, where the counties are that were selected for the sampling throughout the country. The data has, because it's one of the few data sets that are publicly available on China and have really been collected at a very kind of high standard, meeting I think most international standards, and even has been innovative in some respects in how it does the actual survey operations. It has gotten a lot of attention. A lot of participants have registered to use the data. So this is just a plot of the cumulative number of users of the Charles data over time. And you can see, as of earlier this year, there were already over 6,000 registered users. And as someone who travels regularly in China and in other places and meets people interested in doing research on China, I know anywhere you go now, there are graduate students downloading the data from Charles and trying to do research and exploring a very wide variety of topics. There are over 50 publications already using the baseline survey data, and that's really, I think, just the tip of the iceberg. So it's getting a lot of use, which is terrific to see. And when we compiled a report of the basic facts or the main findings, descriptive findings from the national baseline, the report received quite a lot of attention. One were these just simple descriptive numbers on consumption poverty and income-based poverty from the survey. And you can see for the 60 and older group, the poverty rates are higher than the 45 to 59-year-old groups, and reach 23% if you measure by consumption, which is perhaps the preferred measure, and even higher if you use income as the poverty standard. And the findings from the National Baseline Survey attracted a lot of media attention. So the Wall Street Journal, CNN, South China Morning Post, this article in Science that I alluded to earlier. And partly it's because even basic facts like the poverty rate of the elderly, although the Chinese government has its own household survey data and could calculate these poverty rates and release them, they've never chosen to do so. They do release some annual poverty calculations and income inequality estimates for the whole population, but nothing specific to specific age groups in the population. In addition, a lot of the descriptive facts about the well-being of the elderly, I think, are really fascinating. We found, for instance, that only 47% of elderly received transfers from non-co-resident children, and if you are not living with the children, but do have some children, only 53% are receiving transfers. So they're almost half of the people, even when they're living without their children, are not getting any financial support from their children. Again, suggesting a level of vulnerability which maybe counteracts some mythological ideas we might have that families will always take care of the elderly in East Asian societies, including China. If they do receive transfers, the average amount is 1,700 renminbi per year, which is not a lot, but it transfers to a pretty large share, 37% of expenditures for the elderly who do receive them. So they do seem to be targeted more towards poor elderly. Okay. The other aspect of the Charles survey that has allowed it to document some important facts about the well-being of the elderly are its focus on health as well as socioeconomic status. So from the survey data and the biometric data, the health exam data, we were able to estimate various levels of health outcome, various types of health outcomes, and found that across many of these, the Chinese elderly are in very poor physical health. Perhaps not surprising given the levels of poverty and low levels of education that they experienced when they were young. And you can see, for instance, that 38% report some difficulty with daily activities. That's a level that's much, much higher than in Japan or OECD countries. A third of elderly report suffering some type of bodily pain. You see also that 32% report poor self-reported health. Again, these are rates that are much higher than you would see in Japan or developed countries. Another interesting thing we were able to do is estimate the level of underdiagnosis of hypertension based on actual blood pressure measurements and reports from the respondents about whether they had ever been diagnosed or had any awareness that they might have hypertension. And so we estimated that for urban people, about 30.3% of those with diabetes were not diagnosed. And among rural people, the rate was much higher. 44.4% of people with diabetes were not diagnosed. And among those who were diagnosed, the percent that were receiving some type of medication were 87% in the urban, but only 80% in the rural. So these types of findings, I think, have very direct, draw a lot of attention to problems in the healthcare system. One of the co-sponsors of the HRS survey is the Ministry of Health of China, the research center under the Ministry of Health. So these numbers get back to the policymakers. China also has recently expanded healthcare insurance programs, most importantly, a large rural cooperative medical health insurance program, which now, if you look at the bottom chart, covers 66% of the population. Almost all rural people are now covered, which is a dramatic increase from just a few years earlier, from the mid-2000s. So we can document the levels of coverage in the population and show the government's effectiveness in expanding coverage, but we do find that the quality of the care, the quality of the assurance, the benefits that it ties, especially to the new programs, are relatively modest. Okay. And then the other thing, finding that was really kind of surprising is the high level of elevated depressive symptoms that are experienced by the elderly in China. So on average, 40% of the elderly report elevated depressive symptoms. I'll show you this is much higher than in Japan and even than Korea, and especially high for females. I skip this. Okay, so in the remaining time, I'm going to also follow a couple of the earlier presentations and provide a few examples of papers or research projects that have been done with the Charles data that have particular policy relevance. So one interesting paper is looking at the effect of this new rural pension program that China's introduced on the labor supply decisions or retirement decisions of rural people. Now, rural people in China are well known to kind of work until they can't work any longer, work until they drop, typical in many rural societies. But China, just in the last 5 years or so, has been rapidly scaling up a rural pension program where people above 60 get a monthly payment from the government, and people below 60 are incentivized to contribute to a pension program where they pay a small amount of money matched by a much larger government subsidy, and this entitles them to benefits in the future when they retire. So the current LDR are just kind of paid, and the younger people are incentivized to try to start contributing into towards their future payments that they will receive. And because China is introducing so many new policies, and these policies are implemented often differently in different regions of the country, we can actually get a lot of policy variation across time and space, and do that without actually having to go to many different countries like Cher does. We can generate some policy variation and do something with that. And so this paper, and this is just using the national baseline data, does that and exploits the fact that you can compare people who are just below 60 and ineligible for the benefits, and just above 60 and eligible for the benefits, and see people who just start getting these government payments, does that really change how they behave? In particular, does it change how much they work? And this may have implications for how China thinks about the effect of these programs on the country's labor supply, but also on the well-being of the elderly. Maybe it's a good thing that old people can stop working a little bit earlier rather than work until they drop. So in this picture you can see, this just shows that if you just look at age and see how the probability of receiving this pension changes with age, you can see that there's a big jump at age 60, which is the official eligibility rule. Now, it only goes up to 40 or 50% on average, which means there are a lot of people not getting it, even when they're eligible, and that's because when we did the national baseline survey, the program had not been expanded to the whole country yet. It had expanded to about half of our survey villages in rural areas. So we can actually do this comparison, but also do a comparison of this difference between people above 60 and below 60 in places with the program, and a similar comparison in places without the program, so have another kind of control group. And when the authors did this, they came up with this finding that indeed having access to these rural pensions increased the probability of not working by 25% at that margin, which is a big effect. It also had a modest effect on poverty reduction. There's some weak evidence that it may have crowded out some private transfers and reduced depression modestly. So, of course, this is a first study, and as we have panel data, we'll be able to identify these effects much more convincingly. But I think, again, it's a good example of the value of this type of survey in a context in China where many things are changing very fast, especially the efforts by the government to roll out a variety of new policies. Okay. Another paper that I've been working on with a graduate student of mine at Hong Kong University of Science and Technology looks at healthcare expenditures and tries to understand some of the patterns that we're finding in how health expenditures change with age. Obviously, this is also often a big issue in many countries, that expenditures often increase dramatically at higher ages, and so have lots of implications for how individuals or the government finance those required expenditure needs. And the starting point of kind of this paper was an observation that if you just plot the household per capita total expenditures by age and do it separately for urban and rural households, you get this pattern on the upper left-hand figure, okay? And you can see there's a big difference between urban and rural. Not only is the urban level of consumption much higher than the rural level, reflecting China's very large urban-rural gaps, but the urban household per capita total expenditure really stabilizes with age and even increases with age past 65 or so. Whereas for the rural, you see this really steady decline in expenditures per capita. So there's quite a different expenditure age pattern in rural China compared to urban China. And so then our first instinct was, where is this coming from? What category of expenditure explains this divergence? And if you look at the bottom left-hand panel, you find the answer, that it's all being driven by this difference in the healthcare expenditures patterns with age. For urban China, and this is the out-of-pocket expenditures, but the qualitative picture is the same even if you look at total expenditures, including reimbursed expenditures. And you can see that in urban China, like in most, at least developed countries where all of this has been well documented, you see a very dramatic increase in spending on healthcare expenditures with age. Not surprising, people are getting less healthy as they get older. But in rural China, you see this very flat pattern, okay? And this is not controlling for anything, which means we know in rural China people are also actually in much poorer health than in urban China, and of course their health is declining with age, but expenditures are not increasing. So this kind of points to something worth study. Why aren't rural people utilizing healthcare services even after the Chinese government has made all this effort to expand its health insurance program to cover almost everybody in rural areas? And so we did some further investigation of that, and I'm not going to report any of the specific regression. Oh, this is the individual data. The previous figures were using household level expenditure data per capita, but now we asked a lot of questions about each individual, so we can get much more accurate individual health expenditure data. And we just repeat the same exercise, and here you can see it even more dramatically, the urban-rural difference in the right-hand figure, where urban expenditures are increasing dramatically with age, and rural expenditures are actually falling with age. And again, this is not conditioning on anything. And so we did an analysis where we tried to control for many things that are changing with age in a regression analysis. And we found that a lot of interesting patterns, that if you're economically active, the age spending patterns are different. One other thing is if you live with grandchildren or non-adults, if you're an old person and there's a child in the house, you're even less likely to spend money as you get older than if you're not living with a child, suggesting that one possible motive of the elderly person or the family is that they don't want to waste the family's scarce resources on their own medical care as they approach the end of life and dealing with these health issues. They'd rather, the family or the elderly person themselves would rather preserve those resources to invest in the younger generation. And that's one possible explanation. There certainly are other explanations. The other thing we found is that having good quality insurance, and by good quality insurance, we differentiate the kind of employer-provided insurance programs, traditional health insurance programs in China, which give very good benefits, to these new programs like the rural health insurance program, the program in urban areas for dependents, which are aimed at trying to increase coverage rapidly, but have very low levels of benefits. And we find that if you have good insurance, you don't see this pattern nearly as strongly of falling expenditures with age in rural areas. But even when you control for that in the regressions and control for everything we can think of, this difference in the urban pattern and the rural pattern persists. Okay, so it suggests that there's something very fundamental about the incentives or the behavior of older people in rural areas that differs from urban areas and raises possible concerns about rural people not really seeking or benefiting from healthcare services as their health deteriorates with age. Now, of course, to the extent that these are voluntary choices, they may be, from the household's perspective, welfare maximizing given alternative choices, but it certainly raises a lot of question, I think, for further investigation. Okay. And finally, I want to talk about a couple of comparative research projects, one of which was mentioned in one of the opening comments. We're working with Professor Ichimura and Professor Sawada and some colleagues from RAND and Korea to try to do some comparison of understanding the well-being of the elderly in China, Korea, and Japan, in East Asia. And our goal was to really understand how the well-being of the elderly differed with respect to different dimensions of well-being: depression, physical health, poverty. And we ended up focusing especially on the differences in depression because Korea and China both have some of the highest elderly suicide rates in the world. Japan used to have one of the highest elderly suicide rates in the world, now much lower. And part of the idea here is to break, again, this myth that, that families take care of the elderly, and so the elderly we don't have to worry about the well-being of the elderly, in East Asian societies. That is a perception, I think, that many in Western societies may have. But in fact, there are many groups of elderly, of vulnerable elderly in all three countries, and the nature of those vulnerabilities may have some common elements, but may be very different. Okay? And we spent a lot of time trying to harmonize the specific measurements in the surveys to do very comparative analysis, where we're using exactly the same measures to do exactly the same kinds of regressions to be able to compare the relationships. And so we focused on depressive symptoms and looked at demographic determinants, economic determinants, family and social determinants, health determinants, and we tried to make the data sets as comparable as possible by focusing on survey waves that were done at about the same time, by focusing on age groups that were all covered by all three surveys. And this first project is just looking at cross-sectional data in three countries, partly because Charles still only has the national baseline wave. The first follow-up wave data is just being released. And we harmonized the measurements, as I said, and used regional controls in all of the countries. And just to show you the outcome variable here, the difference is China, again, and this is for the same age sample in the three countries at basically the same point in time. The propensity or frequency of elevated depressive symptoms is highest in China, then Korea, and then Japan. And if you look at roughly similar measurements for the US, I think you get measurements between 11% and 13% of elevated depressive symptoms. So Japan is pretty close to the US, but China and Korea are much higher, especially China. Okay. And then, we put a bunch of we try to look at how different sets of factors explain differences in depression in each of the three countries. And some of the relationships you might think would be similar across the three countries or any countries turn out actually not to be similar. For instance, the age gradient, once you control for other things, is quite different in the three countries. So and the way to interpret this really is, you know, a higher number means more depressive symptoms. So in Korea, there's a very sharp increase in depressive symptoms as you get older. In Japan, it actually is the opposite. Once you control for health and other things, and economic factors, et cetera. And in China, it's kind of non-linear. You know, it goes up until age 65, 71, and then the older group here, actually 72 to 78, now declines. Now, of course, this could be just reflecting differences in the lifetime experience of different birth cohorts in the different countries, because it's just cross-sectional. And so we hope to do similar analysis using panel data in all three countries. Then we can really identify some of these things a little bit better. But it raises a lot of questions, obviously, about what's underlying these differences. Some of the other things that we found is doing some kind of simulation analysis from the results of the regressions was that physical health has by far the largest explanatory power for high depressivism in all three countries. So if you wanted to figure out which groups you should be looking at in terms of risk of high depressivism, it's going to be the people who have physical health problems in all three countries, and probably much more than any of their factors. In China, and especially Korea, and this is also consistent with a lot of other research and popular kinds of discussion of the elderly problems in Korea, the economic factors are very strong predictors of depressive symptoms. Korea has not built up a very complete safety net to support, to provide benefits to prevent the elderly falling into poverty, et cetera. And education is a very strong predictor of depression in China and Korea, much less so in Japan. But that's because in China and Korea, the elderly are much less educated. Today's elderly are much less educated than today's elderly in Japan. In fact, most elderly in China are illiterate or have not completed primary school. I mean, the majority. So it's just a very different population. And so we've also tried to do some analysis where we try to compare, because they're obviously not very comparable to Japanese when the education levels are so different. But even when we try to control for people in similar education groups, we find kind of similar relationships. And the other thing, things that were interesting for China and Korea was that it wasn't so much how much money you received from your children, but how often you had some kind of contact with your children that affected depressive symptoms. And also measures of social activity also were associated with lower depression in China and Korea. Of course, many of these are not causal relationships. They could work the other way, obviously, that depression could prevent people from being socially active, et cetera. But we're just trying to understand what are the kind of associations in the data initially. And finally, we have a study working with James Banks and others in ELSA comparing China and England. And I don't have much time left, so let me just show you what we try to do is try to understand how much does well-being change with different wealth quintiles in China and in England. So how much does the inequality in wealth really determine inequality in well-being of the elderly? And one interesting thing we found was that for physical health, for self-rated health and other physical health measures, the gradient was much stronger for ELSA in England. That was more associated with health differences, the wealth inequality, than in China. But when we looked at psychological outcomes or mental health outcomes, like depressive symptoms, we found that wealth differences were much more strongly associated with differences in mental health in China than in ELSA. So that led to a lot of thinking about what might explain these findings. Why is wealth less correlated with physical health in China than in England? It could be that in China, the current wealth differences are much less correlated with lifetime wealth differences because China's kind of very tumultuous history over the last half century. It could be that there are other equalizing factors in China related to community factors, which we know are very important in China, or socialist legacies. Or it could reflect that the quintiles mask the fact that maybe inequality overall is greater in England, and so leads to bigger health differences. And then for the psychological well-being it could be that people in China are more dependent on their current wealth for their livelihood. Social Security is less important in China and not really measured. It could be something about the importance of relative wealth being more relevant than absolute wealth, and that subjective well-being being much more reflecting your current circumstances, or much likely to be changing based on the most recent experiences. So let me stop here. Thank you very much. Oh.
Thank you very much. It's an honor and a pleasure to be here. I want to thank the people at RIETI for making this possible, and thank you all for being here. What I'm going to talk about today is really to try to give you some examples of how the health and retirement study in the United States has informed the policy discussion and the policy debate pretty much from its inception and continuing on until now. And in order to do that, I'm going to focus on a number of studies that have been put out by the Government Accountability Office in the U.S. Government Accountability Office is an independent, nonpartisan agency that is part of the federal government. It's been deemed the congressional watchdog of the government, and one of their main mandates is that they their research addresses how the government is spending taxpayer dollars, and they have used the HRS extensively. There's been a lot of studies with the health and retirement studies and study in the academic arena, more than 2,500 academic publications, and you've heard about a number of publications with all the different HRS type studies, and so what I wanted to do today is really talk about how the government is using it to inform policy. Let's see. Sorry. Oh yeah, sorry, okay, sorry, thank you. Okay, so just as a bit of background, and Mike Hurd already had a picture that was something like this, but just to motivate why this is important. For the better part of, I would say, the last 4 decades, or at least if it was earlier than that, I don't remember because I wasn't old enough. But for the better part of at least the last 4 decades, there's been a lot of policy debate surrounding the changing demographic landscape. And as you all know, the changing demographic profile is occurring not just in the US, but even more so in Japan. And there's been discussion about the impact of this changing demographic profile on government and macroeconomic budgets. And I think there have basically been two dimensions of the discussion. One is that in thinking about the budgetary impact and the increasing budgetary impact that the increasing longevity is going to have, there's been some discussion on the importance of ensuring that retirement income continues to be adequate for the aging population, ensuring retirement security. And there's been a lot of discussion about the difficulty that people have in saving when their longevity is uncertain. So in some ways, people have to effectively oversave to take into account this uncertainty. Early on, there were a number of proposals to address the Social Security solvency problem. This is not unique to the United States. Most countries in the developed world have having similar discussions, especially post-financial crisis. And some of those proposals focus on either shifting more responsibility for savings to the individual and away from the employer. We think about moving from defined benefit pension plans to defined contribution, and then other proposals really think about the need, or recognize the need to address the budgetary challenges by things like raising retirement ages or encouraging people to work longer. I'm going to go through now a few of selected policy evaluations, and I've arranged them by theme, so it's not exactly chronological, but it's by theme. I'm going to highlight 2 that are related to these 2 Social Security Social Security solvency issues, and then I'm going to briefly describe a few other policy issues. Now, very early on, one of the, and this predates the health and retirement study, there was, in the original HRS cohort, so in 1992, this just shows the percent of different men and women, so it's by gender, by what the average index monthly earnings category. That's basically what our Social Security benefits are computed based on. And one of the things that we learned very early on with the health and retirement study is just how skewed that distribution is, that women really enter into, or the Social Security payment that they receive is significantly less than what men would receive. And so a number of studies were mounted to address this issue, concerns over the fact that because women live longer, there's a much greater prevalence of poverty. There was certainly of poverty among women. And so a number of studies were mounted to try to address this, again, both in the academic community but also in the government. So the first study I want to highlight is a study by the Government Accountability Office. I've put on all of these slides the URL that provides the access to the actual report, so you can read it more specifically. But this first study was designed so that the GAO, the Government Accountability Office, was mandated to examine why women's Social Security benefits were so much lower than men's, in some sense based on that first graph that I showed you. And the other thing they were asked to evaluate was whether reform proposals, so these proposals to do things like raise the retirement age, might have different effects on women than on men, and how to minimize those potential negative effects on women. So what they did was they used both the HRS directly. They also cited research from academics that were using the HRS. And what they found was that proposals to fund, they developed proposals to fund retirement savings via accounts that draw on a proportion of the salary. What they found was that could actually make the disparity, so the difference between men and women, much worse if, in addition, women have different investment behavior. They came out with a number of policy recommendations based on this. So in the study, they made policy recommendations, and again, these are recommendations to Congress. And so some of the recommendations included improving information about investment objectives and financial planning, so making sure that the information is out there to individuals, trying to equilibrate or balance what women's investment behavior versus men's. Consider mandatory annuitization of pension benefits to reduce the possibility that a person would outlive their savings. And then there was another one that suggested that they use unisex life tables, so rather than distinguishing between men and women, just use a single life table, and that would ensure that those with comparable savings at retirement actually receive comparable monthly benefits throughout their lifetime. A second study, about 10 years later, evaluated the incentive effects that are contained in Social Security, Medicare, and the pension rules, and documented recent retirement patterns and whether changes in Social Security requirements have actually resulted in the later retirements. What the GAO found using the health and retirement study was that federal policies offer mixed incentives, and the recommendation that they had was that Congress may wish to consider changes to law, programs, and policies that support retirement security, including retirement ages, in order to provide a set of signals that work in tandem to encourage work at older ages. One of the things that's very nice about the health and retirement study and the other studies like it is that there's such a comprehensive amount of information contained in those studies that you can compare these differential effects across different programs. So rather than looking at a single program in isolation, it's much easier with something like the health and retirement study or with JSTAR to be able to look across programs and see how those programs interact with each other. A third study related to Social Security was one, and so as I mentioned just a second ago, the nice thing about the health and retirement study is that you can look across different policies. So one of the things with this study, the question that was asked is first of all, what are the characteristics of those nearing retirement, and how long is it, or how likely is it that they will be able to continue working if we raise the Social Security retirement ages? So the Social Security retirement ages used to be early retirement age at 62, regular normal retirement age at 65. now we have a policy that has increased the normal retirement age to age 67. It has left the early retirement age at age 62, and one of the reasons for that is that the policy was, or these policies were informed by the HRS and its predecessor, the Retirement History Survey before that. One of the things that was found is that for a small group of people, increasing the early retirement age would really, there is a small proportion of people that are not able to continue working past age 62. And what the studies found is that if the early retirement age were raised, that would actually result in increased applications for disability insurance. Or disability insurance is a much more expensive program to administer because there are verifications that have to take place as to whether or not people actually are disabled. There are follow-up procedures if somebody is denied disability benefits as well. And so what the studies described was that if the early retirement age were raised as well, that would create a greater burden on the disability rolls. And so as a result, through the policy, early retirement was left where it is, and there are now these incentives that encourage those that are able to work longer to work longer. So the policy analysis, the main thing was that while policy options exist to mitigate the impact on affected workers, doing so will likely require expanding programs and increased benefit costs. And so this study emphasized that it was important to find a balance between worker protections and the costs. The next set of policies the next set of policies or studies that I want to highlight are studies that really address that second part of the graphical slide that I showed you, which is studies that have looked at how do we assess retirement income adequacy and how do we improve retirement income security. In 2003, the GAO identified an issue, which was that individuals face increasing responsibility for ensuring the sufficiency of their retirement savings. As I mentioned, this is in some ways a result of the shift that we've seen in the United States from defined benefit plans to defined contribution plans. So as that shift has created increasing responsibility for individuals, the GAO was asked to study whether or not those individuals are actually equipped to take on that responsibility. Using the Health and Retirement Study, the GAO found that while plan sponsors provide timely information about these options, so things like whether you receive your benefit in a lump sum versus an annuity, there's very little discussion regarding the relative risks of the available options or the risk of outliving one's savings. So that even though the actual information is provided, individuals are not, or at the time were not equipped to actually assess that information or to interpret that information. The policy recommendation that came out of this study was that more effort was needed to increase public awareness of these risks and the implications for lifetime income adequacy of different options. Among other things, that has resulted in, for instance, annual mailings of the Social Security Administration to all of the citizens that provide information about what the benefit levels or benefit amounts would be if people retire at the early retirement age, the normal retirement age, or a delayed retirement age of age 70. So a lot of the actual implementation of this came out of studies like this that identified that people really needed more information in order to make the kinds of decisions needed to ensure their adequacy. This has led, in addition to the Social Security Administration mailing, studies like this have also led to a series of financial literacy initiatives going on in the U.S. Another study in June 2011, GAO was asked to evaluate the pros and cons of various policy options to enhance retirement income security. And what the GAO found was that retirees rely primarily on Social Security, and they typically pass up opportunities for increased retirement income, so elective opportunities. Of those who have things like pensions, few retirees choose the annuity option for receipt of their defined benefit pension income. And the other thing that they found in the Health and Retirement Study was that elderly appear to draw down their savings relatively gradually. Among the policy recommendations that came out of this study were, one, to encourage annuitization. That's a theme that has been common to many of these studies. And again, another theme that we've seen that's quite common to these studies is to improve financial literacy so that people are aware of both their investment options, but also the associated risks to those options. Now, in addition so a lot of what we focused on with the health and retirement study and the related surveys is our policies or issues related to individual decision making. So things like how people decide to retire, what their income adequacy or income security, what their level of income security is, et cetera. But I think it's also important to emphasize, and as I said, the wonderful thing about these data sets is that they're incredibly comprehensive and that they cover a wide variety of different pieces of information that can be brought together to really talk about economic policies more generally. So in addition to individual decision making, a rich data set like JSTAR, like the health and retirement study, also informs policy decisions about macroeconomic conditions. I was at the Federal Reserve for a number of years before coming to American University, and both I and my colleagues at the Federal Reserve used the health and retirement study in order to assess and evaluate macroeconomic conditions. Again, citing Government Accountability Office studies, there were two, one in 2001 and one in 2005. The main question of both of these studies was what areas of the labor market are most affected by the aging workforce, and what can employers do to recruit and retain older workers. Using the health and retirement study, the GAO found that the aging workforce is likely to affect all areas of the labor market, and that was really quite significant. One of the things that they emphasized is that older workers may be an increasingly important resource for employers, and so a number of policies were put forth related to that to try to encourage people to stay in the workforce longer, to take advantage of the opportunity to have older workers in the labor force. Now, although few, and the other thing that they found was although few employers have begun to prioritize programs to encourage recruitment and retention of older workers. So some of those programs are things like flexible work arrangements, having accommodations for workers that are developing health or other kinds of limitations. Many employers actually have expressed a willingness to have these programs. So as a result of these studies, the GAO recommended designing a public awareness program to improve planning for both employers and employees in that phase out or in the phase towards retirement, things like partial retirement or more flexible working hours, particularly focusing on the question of retention and the recruitment of older workers and providing assistance in finding opportunities for those older workers to continue work. The Department of Labor actually agreed with the recommendations of the Generalized Accountability Office, and as a result of these studies, initiated an outreach campaign where they identified initiatives to encourage employment of older workers. They also convened an interagency task force, which continues today, that was focused on addressing future demographic challenges. I think one of the things that's important about this last point, that the Department of Labor, as a result of this study, agreed with these recommendations, is that one of the other things that the health and retirement study has done in the United States is that it's facilitated interagency cooperation and interagency buy-in. So before, if we didn't have studies like this, each agency would do its own analysis, maybe collect its own data, but this has provided a single unified resource where different agencies can look at the same data, do analysis, and collaborate and cooperate together in shaping policy. Another question that came up in 2006 that was looked at was the question of, will the retirement of the baby boom generation, Mike HURD talked about the baby boom generation earlier today, so those born between 1946 and 1964, will that cause a stock market meltdown as this generation shifts out of equities and into lower risk assets? Certainly earlier on, there was this notion that and a lot of financial advisors will recommend that as people approach retirement and older age, they shift their portfolio from stocks to bonds. Because the baby boom generation was such a large cohort, there was a lot of concern. I remember this when I was in grad school. There was a lot of concern that suddenly the rates of return that we're used to seeing would decline because we'd see this entire cohort shift into bonds, basically from stocks. Using the health and retirement study, the GAO found that a sharp and sudden decline in financial asset prices was extremely unlikely. A number of reasons for this. One was that many of these baby boomers actually have few financial assets. So if you don't own stocks, there's nothing to shift from stocks into bonds. Another was that the increasing life expectancy actually meant that baby boomers would have to work longer, and therefore they would, and as a result of that increased longevity, they would actually spread their asset sales out over a longer period of time. So again, even though there might be a change or a shift in portfolio, it wouldn't be as sudden as people were fearing. Another finding, retirement income security would likely depend, and this echoes some of the previous studies the GAO did, would likely depend increasingly on personal responsibility. Another finding was that workers' retirement depends not just on the pension benefits or Social Security benefits, but it also depends strongly on retiree health insurance, the availability of retiree health insurance. And again, one of the things that they echoed is that it suggests an important role for financial literacy initiatives. Now, one of the other things that was nice about having a longitudinal data set like this is that the HRS core data can isolate the effects of recession from other changes over time. I think this is extremely important. When I was at the Federal Reserve through the beginning of the financial crisis. I actually left 2 weeks before the Lehman Brothers debacle. But basically, one of the things that we talked about a lot at the Fed was the idea that you can't wait until you need the data to collect the data. In shaping policy, and especially in responding to crises, it's really important to actually have a large data set in place already so that you can compare and evaluate what's happened during quote-unquote normal times to what's happening as a crisis is unfolding. And so the nice thing about the health and retirement study, having been around for so long, is that we have a large baseline of data that we can use to then inform what happens when we see a giant change in macroeconomic conditions like we saw with the crisis. So you know, we've already talked a little bit about some of the data that's in there, but one of the things that you can look at is that that you can look, for instance, at the changes between permanent versus temporary layoffs, how changes in firm policies for older workers affect employment, and you can evaluate or look at involuntary reductions in hours. You can also look across firms at whether there are changes in compensation that were related to and how that isolate the effects of changes in compensation and how that affects individuals versus other changes. The longitudinal panel in the HRS is also very useful for analyzing the financial effects of market shocks. So as I mentioned, the HRS was in the field both before and after the recession. And those who speculated about the effects of the Great Recession on retirement, so as the Great Recession was unfolding, as the financial crisis was unfolding, there was speculation that this would lead to long-term effects. And those who speculated, for the most part, got the story wrong. A major focus as the crisis was unfolding was about the effect of the decline in the stock market and the massive decline in housing prices. And so, for instance, a lot of people back in 2008 predicted that losses on defined contribution plans, so again, remember that we had shifted the responsibility for retirement income security and retirement adequacy to the individual. All of a sudden, the financial crisis hits. Individuals are experiencing large losses on their defined contribution balances. There was a lot of concern that this would lead to large reductions in balances, and therefore reductions in retirement rates, that people would stay working longer. First of all, in terms of the financial crisis, there was actually limited importance of defined contribution plans for those that were on the cusp of retirement. So those that were about to retire, for the large part, still were people that had that were facing defined benefit plans. The shift to defined contribution has happened for the younger cohorts. The decline in wealth due to the recession was actually greatly cushioned by pensions and Social Security. So on average, people have around 29% of their wealth in Social Security, another 17% 17% of wealth in defined benefit plans. So most near retirees were actually not immediately affected by the decline in housing prices. Their homes were not extensively mortgaged. Most of the people who were nearing retirement actually had already paid for their homes, and they would therefore use their money many years later. Now, in terms of the prospects for international comparisons, Axel mentioned benefits, that one of the great benefits of having the HRS, ELSA, SHARE, JSTAR, et cetera, is that it facilitates these cross-national comparisons. It's very important for identification of some of these effects. So, for instance, if a recession hits different countries differently, even the past financial crisis, then we can use the timing variation. So to the extent that the most recent financial crisis started with a mortgage problem in the U.S., hit the U.S. first, then it migrated to Europe. Possibly the effects of that are being felt elsewhere in the world now. That timing differential can be used to separately identify the impact of a recession on individuals. If instead the recession had a similar impact on all countries, so for instance, if we think about Europe and SHARE, we can still look at the variation, the cross-country variation, so looking at differences, for instance, in social safety net or other social policies in order to identify impacts. And if there are differences in how the recession affected different countries, and they have a very different social insurance system, then in some ways each country needs to be analyzed individually. I think the final thing in my remaining 5 minutes that I want to mention is that the other benefit of this longitudinal data, and some of the previous speakers have discussed this, is that longitudinal data can also be used to identify further data needs. So despite the wealth of information, the people who collect and analyze these data are constantly evaluating and staying proactive in terms of identifying future topics of inquiry. So again, these data are incredibly important in being able to think about what information, in being able to proactively identify potential policy concerns before they become a policy concern, because we start to, as you've seen in from the previous speakers, we start to identify patterns in the data that leads to academic questions as to why those patterns exist or how we can modify those patterns, and that then ultimately leads to the policy discussion. So important in these data is the ability to identify needs before it becomes a front and center policy debate. So one of the things, and the GAO has been involved in this as well, so the GAO in March 2003 basically had a report that analyzed what are some of the critical data needs for studying issues related to the elderly. And using the health and retirement study, they found that more data are needed regarding administrative and employer records, as well as linkages to other data sets. One of the things they emphasize is that one of the impediments to data collection, they emphasize that any impediments to data collection would lead to a fragmentation of responsibility, resulting in smaller data collections without linkages. And so two of the recommendations that came out of this study, both of them have been enacted in terms of policy, and I think have really enhanced the health and retirement study over the last 10 or so years. They both recommended that the government develop a plan to collect and coordinate data collection across agencies, and they also recommended that copies of summary plan descriptions from employers be obtained. And that was something that the HRS, the Health and Retirement Study, has done that has really improved our ability to look at pension plan provisions and how that affects retirement decisions. We had a lot of information in HRS and collected a lot of information from the individuals about their pension plans, but what we found is that by linking to the summary plan descriptions from the employers, we can use that both as a cross-validation technique to assess and analyze the information that individuals are providing, but it also helps to round out some of the analysis, almost like the benefit of collecting objective health information in combination with the subjective health information. As a result of these increased linkages and the summary plan descriptions, there's some recent work by Alan Gussman and Thomas Steinmeier. I should mention I'm grateful to Al Gussman for providing some of these slides. But what they have found in a series of papers is that the linkages with social security administrative data enable us or people working with HRS to identify the degree of misinformation that exists in the surveys. And what they have found is that there's a lot of misinformation about pensions and pension values. Now, I want to be very clear that a lot of people sort of stop right there and say, oh, well, okay, so survey data, we always knew that there's misinformation. But one of the things that's important is actually this informs the financial literacy debate and the policy recommendations regarding financial literacy. Identifying this misinformation is very important. So first of all, they found that only half of respondents could correctly identify their pension plan type, and fewer than half could identify their date or age of eligibility for either early or normal retirement within a one-year window. Misinformation as well about Social Security. I mentioned that the Social Security Administration sends out reports to every individual describing what their benefits would be if they retire at certain ages, but only 50% of respondents in the HRS could venture a guess as to their expected benefits, and only half of those came within $1,500 of their actual benefits. Again, my read of this, or I think what this emphasizes is how important it is to follow up information. We can always say, let's give additional information to people, but really to help them interpret and understand how to use that information in making decisions. I think that's one of the most important aspects of these longitudinal data is in helping us to identify that. So policy responses to some of this work is the need for increased information and increased financial literacy initiatives. Finally, just to conclude, in its 22-year history, the Health and Retirement Study has been absolutely invaluable for policy, both in identifying areas that need a policy response. So, as I mentioned, that proactive identification of things where policy needs to be developed in order to respond, and then also in evaluating the effects of policy once it's been enacted. So it has allowed the government to evaluate the effects of policy once policy has happened. Linkages with administrative data enhance the value of both and allow for both in-depth analysis and identification of public misperception that, again, can be addressed in policy. The longitudinal aspect is critical. I cannot emphasize that enough, especially as the population ages. Thank you.
Thank you very much. It's a great pleasure to be here and to hear all about the success of JSTAR, and also to have the opportunity to tell you about some of the other studies that we've been running around the world. I'm going to talk today about the English longitudinal study of aging. I'm going to not focus so much on the academic findings that have emerged from that study, but instead I'm going to speak more about some more descriptive work that has been used by the British government in informing the policy debate. What is ELSA? ELSA, the English Longitudinal Study of Aging. You can think of it just like JSTAR, except for it started in 2002. And an important difference between ELSA and the other studies you've heard about today is that half of the money we receive to do this grant, to do this project, actually comes from the government agencies who are running policies themselves. So it's not the research department of the government that is funding ELSA, but it's actually the Ministry for Work and Pensions who are designing pensions policy, or the Ministry for Health. And so these agencies, these government agencies, actually fund the ELSA study, and we talk to them a lot about what information they would like to know and how they would like to use it. Much as with the other studies, the key characteristics of ELSA are that it is a multidisciplinary project. It involves economics and health, sociology, psychology. It samples a representative sample of the population, age 50 and over. It's a longitudinal study, and it's an open access study. So all the data are made available for researchers, and they're made available for government officials and departments who also use the data in their analysis. We collect data every 2 years. So we interview our respondents in 2002 and then in 2004 and every 2 years. And every 4 years, in 2004, 2008, and 2012, we also have a 1-hour nurse visit where we assess their physical health and collect various different biomarkers. Over the course of the period so far, we've interviewed approximately 18,000 respondents. Before I tell you about the way in which ELSA has been used by the government, I need to tell you a little bit about the context of policy in the UK with regard to an ageing population. And over the last 30 years, we have had a major movement in policy which has shifted the responsibility from the state to the individual, much like we've just been hearing in the US. So pensions, government pensions are now much less generous than they were. Private pensions are encouraged. Various incentives to retire within pension systems have been removed. And in fact, there's an ongoing program of pension reform. So within the financial sphere, individuals are expected to save much more for their retirement now than they were, and much more than in many other European countries, for example. This has been a long-run trend over the last 30 years. But right now, in Britain, over the last, say, 4 or 5 years, we've had many, many reforms going on. We're having, I will tell you about this in a few minutes, we're having a program of increases to the retirement age. We're restructuring totally the level of disability benefits for older workers. We used to be one of the only countries in the world that had mandatory annuitization, and we've now removed that, when many other countries are talking about putting it in. We've also had a period of time where the UK government has been really protecting the living standards of older people from the recession. The way in which the benefits that older people have been receiving has been indexed is ensuring that their living standards are staying constant when younger groups of the population are being hit by the recession. Alongside that, we're also now, for the first time, having a program of extensive reforms to the way that social care and health care are organized. And all these reforms are taking place at a time where we have ELSA data following people through. And our government agencies are now using the ELSA data to monitor how these reforms are working in the population. One other, it may look like a very small reform, but I want to focus on it just at one point in the talk, is a reform called digital by default. So our government is now moving to a system where they want to engage with the population digitally. So you would claim your benefits on the web, you would receive emails from the government, and you might even have most of your payments paid electronically into your bank account rather than through benefits officers. Now, of course, this may well impact on older people who don't have so much access to the internet, and of course we can measure that in our study, and that's one of the things we've been talking to the government about. Really, what does this mean? This means that in Britain, with regard to pensions and finance, the debate is not about can we afford to grow older as a society, because the cost of the programs has really been reformed such that it is sustainable. The issue really is about whether people will provide for themselves. So will they work for longer? Will they save for retirement? Or if not, are we looking at future scenarios which have higher pensioner poverty and higher pensioner inequality? On the health and social care side, it's very different. There, the policy debate is really about what is the current quality of the care that people are receiving. Could we even afford to continue to provide that with a higher fraction of older people? And how would the government try to redesign the system to provide acceptable quality at lower costs, at least lower public cost if possible? The final broad context is that the government policy is being expressed not just in terms of finance or health, but in terms of a broader target for well-being, quality of life, and statements where the view is that retired elderly populations the government wants to encourage retirement as an active period of life where people can work and contribute to society, but simultaneously taking personal responsibility. Now, the reason I say this is because measuring well-being, measuring activity, and measuring participation in society has become a very big policy issue in the UK. And again, this is something where the surveys such as the HRS and JSTAR can do can add important value, because we have many measures in these dimensions that we can correlate with the other more traditional dimensions such as income or health. This is a little advert for the government. This is the government's website in the UK, and this is the Government Office for Science, which is collecting together various different evidence about aging, and in fact trying to bring it all together to inform government policy across the whole range of government departments. Again, you can see the first thing that it talks about is improving quality of life for older people, and they're collecting all this evidence and bringing it to government departments. So there's three different ways that ELSA has been used by government. The first is the government officials are just using the data to make their calculations. When a member of parliament asks a question to the Prime Minister, how many old people have access to the internet, the government officials have to go and use ELSA data to find out the answer to that question. The second way is when the government launches a major inquiry or commission onto designing certain types of policy. So there was a famous one called Adair Turner, was a famous economist, and he did a special report for the government on what would be the options for pension reform. He may commission evidence from ELSA, amongst other studies, as part of the reform, as part of the commission informing that process. And finally, there's the kind of thing that people like I do, which is just I'm writing research papers that inform government policy, and the government may read them or not, and maybe take them into account. So I'm just going to give you some simple examples. Remember I told you that the state pension age is changing very rapidly. This tells you the retirement ages in Britain. In 2010, they were 65 for men and 60 for women. Over this current 10-year period, the women's retirement age is rising by 6 years. This is very rapid change. And at the very end, the men will go up to 66. And we've already had announcements that in 2028, the retirement age will go to 67. So many things are happening, and we can measure them. I'm just going to focus on one, which is that nobody, or very few women, realize this is happening. This is a figure that says, for the women whose retirement age is 60, the green in the figure represents people who correctly know what their state pension is, their state pension age. So for the women whose state pension age is actually 60, 80% of them, when you ask them, what's your state pension age, they say 60, which is good. But for the women who are being affected by these reforms, whose state pension age is between 60 and 65, only 1/3 of the women actually know what their state pension age is. A number of people get it wrong. in various different ways, and a large fraction of people just say they don't know. And this is just in 1 year. Using the longitudinal data, we can ask ourselves, well, are people learning and getting better over time? And this is the same figure, now using multiple waves of the longitudinal data. The women whose state pension age is 60, actually, those 80%, some of them, if you ask them again, they tell you a different number. It turns out they didn't really know it, and so only 60% of the women consistently say their state pension age correctly. But the fraction of people who consistently tell you, who are in these generations that are being affected by the reform, is even lower. In fact, some of the people, W here stands for wrong, and R stands for right. So some of the people who got it right the first time actually got it wrong the second time when you answer them. So I think the lesson from this is that there's considerable confusion in this period of time when retirement ages are changing very rapidly and in a very important way for women. There's considerable confusion about what these ages really are. And as a result of this, the government has done major innovations in trying to promote and trying to inform women about their retirement ages. The second simple piece of evidence relates to something that you heard from Professor LUMSDAINE about the adequacy of retirement resources. Much like in many countries, ELSA, the aging study, was the first study to really comprehensively measure all aspects of wealth, to include the value of people's pensions, as well as the value of their houses, as well as any potential inheritances that they might receive, and even the value of the paintings that are hung on their wall or the cars that sit in their drive. And so using all this, you can forecast how much people's wealth will generate for them in terms of retirement income under various different assumptions about how long they'll live, their retirement age, and the pensions that they have. And there's many ways that you can analyze this data, and the share data in Europe have been used to the same effect, and as have the HRS data in the US. And in fact, I think even Professor Chimura talked about some similar type calculations in JSTAR. For a long time, our government, the British government, was interested in a particular measure. How many people will retire with a level of income that is at least 2/3 what they used to have when they were working? So this was a government measure of adequacy. They wanted people to have at least 2/3 income when they were retired than they had when they were working. And you could very easily, and for the first time, look at how many people in the older population were forecast to have less than this level, and how would it depend on different factors. So if everybody stopped work today, well, these calculations were from some years ago, and they only used their pension, then you would have up to 40% of the population failing to meet this level of income adequacy. But the figure shows that when you, obviously, how long you work for is going to affect the level of adequacy, but also substantially whether or not you choose to use all your wealth, or the government chooses to factor that into its calculations. Now this may seem, for an economist like me who's been working in a university and research, this seems absolutely obvious. But it was the first time that one had ever been able to put quantify these numbers for the British population. And of course you can go further. You can do things in a much more sophisticated way. In ELSA, we collect people's social security number, and we link to the government records on the entire history of their earnings over their life, and then we can model very specifically exactly what their earnings were, what their pension will be, and we could even try and make a guess at what an optimal model of consumption and savings would have shown they should have saved, and compare to that. I do have a figure on that in the slide, which actually shows, much like in the US, that when you do this, a lot of British households seem to be having slightly more savings than the model would predict. But I'm not going to talk about that. So that was the financial side. There are many other places where ELSA is being used. I'm not going to talk about all of these, you'll be pleased to know. I'm just going to focus on 3 from very different areas, just to give you an example. I'm going to talk about the quality of healthcare is being received. I'm going to talk about enjoyment of life and how it's very important to enjoy life. And I'm going to talk very quickly about digital inclusion. This is a figure, you probably can't see it in detail, but for people with various different health conditions, we ask detailed questions on what kind of health care they receive. And we've asked doctors what should be done to these patients. If you had a patient with diabetes, what do you need to do? And then we ask our survey, have you had these done? And this figure shows you the proportion of people who've had quality of care that meets these standards. So for example, this left-hand panel is cardiovascular disease. This shows that in different waves of the ELSA data, approximately 80 to 90% of respondents were receiving appropriate care for cardiovascular disease. In other conditions, the level is lower. It fluctuates, but it's been broadly constant over the period. But there are some conditions, notably related to arthritis, pain, falls, and vision, where really older people are getting very poor quality treatment. It's poor, and it's not getting any better over time. You can actually group these conditions, and it turns out that we do very well on average in healthcare at providing care for medical conditions, but rather badly on geriatric conditions. We do quite well on screening and prevention, but quite bad on diagnosis. And the British healthcare system has an organisation that encourages GPs, doctors, to provide certain types of treatment for certain types of diseases. And surely enough, the diseases where the doctors have a financial incentive perform better than the diseases where the doctors do not have a financial incentive. But one thing that is true in the British system is that the quality of care that people receive does not depend on wealth. So if we look at these are the 5 or the 6 different types of treatment that you should have if you have diabetes, and we look from the poorest to the richest of the population, we don't see very much variation in the quality of care received. Broadly speaking, the people in the very poorest wealth group have the same level of quality of care as the people in the richest group. Despite the fact that if I look at survival, so this is what we would know, this figure shows the proportion of respondents who were alive in 2002 that were still alive 10 years later, 2012, split into groups. The highest wealth, the richest, were much more likely to survive, of course, than the lowest. In fact, only 15% of the richest fraction of the wealth distribution died over this period, compared to almost 40% in the lowest fraction. So we see big gradients in mortality by wealth, but we don't actually see any gradients in healthcare. I said I would show you one figure about the internet and email, because the government is interested in delivering all its policies to older people by internet, by digital. This shows the take-up of internet within the panel. This is exploiting the longitudinal study, the longitudinal aspect of the sample, by people of different types. So this figure looks at all the people who, when we first interviewed them, they had no access to the internet. So, for example, 50 to 54-year-old men, when we first saw them, 36% of them had no access to the internet. They said they couldn't. But, this is the top line, over the course of our panel, 70% of those have gone online. So that's a group where you think there's probably no problem. It was a small group with no access, and within that group, they've all joined and they've all gone online. But if you look at older women, even this is not that old, of course, 65 to 69, 77% of them, when we first interviewed them, had no access to the internet. And over the period of that time, only 30% of that group have come online. So it's going to be very hard for the government to deliver policy to that group if they want to deliver it digitally. And the numbers would get even greater if we went to older age groups. I've got two more types of findings briefly in my 7 minutes that I've got remaining. The first is that I wanted to talk about the quality of life. As I said before, our Office for National Statistics is now trying to measure well-being and quality of life with the intention of trying to make that a specific goal for policy as opposed to just financial well-being or health. So they've been developing subjective well-being surveys and measures, and we've been working with them to implement the same questions in our questionnaire. So this is a question which says, overall, how happy did you feel yesterday? Or how anxious did you feel yesterday? And these are subjective scales that people are asked to report. And these are exactly the same scales that we use in our survey as the official government measures of well-being. Well, the first thing that we see, which is rather like the Chinese example, and is, I think, familiar from quite a few countries, is that within the group of older people, happiness and well-being is highest in the middle. The people at the older working ages report lower levels of happiness, and people at the very older stages also report lower levels of happiness or well-being. And that would be true for many other measures in many other domains. But that's really only a very crude statistic. We talked earlier about, in the day, you heard about whether people are alone a lot or the various different activities that they might do to contribute to why are there these patterns? Why is it that people aged 60 to 74 appear to be looking quite well in terms of well-being compared to the other elderly people? We have many measures of this. I'm only going to talk about one. I'm going to talk about loneliness. This is how many hours people spend alone in a day. And this shows you that for men and women, that it's the poorest people in the population who spend most time alone. Women spend more time alone than men. That's predominantly because women are more likely to be single than men. But if you look at what happens when you're alone, if you ask people how happy are you in the minutes when you're alone, actually the richest are happiest when they're alone. So what you have is a sort of double deficit. So the poorest are most likely to be alone and most likely to be unhappy when they're alone, whereas the richest actually quite like being alone. and so and this is a pattern that you observe in many activities. So you can't just, it's not enough to just understand what the level of well-being is. You've got to try and understand where it comes from in different activities and how that changes across the wealth distribution. And this is just to say that if you think well-being doesn't matter, well-being and enjoyment of life is also a very strong predictor of survival. This is the same picture that I showed for survival. What's the probability that you're alive 10 years later, split for groups with the highest enjoyment of life versus the lowest? And there's a big difference in the levels. And when we run a model that controls for all other possible factors that we can observe, health behaviors, depression, and all these factors, we still have a strongly significant effect of enjoyment and life on survival. In my final 3 minutes, I want to talk about something slightly different, which is really the next step for which we've started using ELSA. And it's a step that I think JSTAR should be about to take. It's one that you can only take when you've got 4 or 5 waves of panel data. Because descriptive analysis is really rather unsatisfactory if you want to design new policies. The government needs to know, if I pull a lever, will something move? Correlation isn't good enough. But on the other hand, at least in Britain, a fully structural model of behavior is well beyond the capacity of our government departments to understand, let alone do for themselves. So there's a middle ground, which is what's called dynamic microsimulation. So you don't run a full model of behavior, but you observe what the transitions are in your panel, and then you forecast in the future, assuming that those transitions will continue to occur. It's very much like what Professor HURD told you about in thinking about the future costs, I think, of some of those health dementia care reforms. So there are now 3 major microsimulation models in use in the UK, all of which are using ELSA data. And they look at mortality, health, disability, retirement, and you can build them based on the panel data. And this is the example for one that I'm going to give you. You need to understand mortality, and once you can predict when someone's alive or not, then you can predict whether they're going to be in good health, and once you can predict that, you can predict are they going to get care, are they going to be disabled, are they going to work, and you can simulate the population going forwards, and then you can apply this population to the current policy regime or different policy regimes to try and understand what changes. Let me just give you 2 simple examples from the ELSA dynamic simulation model. This is the official projections for the distribution of family types by the Office for National Statistics, which does not use microsimulation. It just uses straightforward demography, where they predict the fraction of single females, couples, and single males in the population aged 85 and over. If we run a microsimulation policy of this using ELSA, we actually see rather different numbers. In particular, we're predicting much more women in particular, but couples in the 85 and over group than the Office for National Statistics. Why? Because we're measuring the degree to which all the household circumstances are correlated with mortality, and we're using all those correlations to forecast forwards rather than just thinking about the single woman or man in their entity. And this, of course, this difference between the number of couples and singles is a very important difference for the operation of policy, because many policies are very different. We're predicting big rises in the number of workers, predominantly to do with the retirement age. And in fact, what you can see, if you look at the distribution of incomes, forecast incomes, this is the current distribution of income between the poorest and the richest by different types, state pension, private pension. You can see that between now and between 2020, which is this number, you can see a big widening in the distribution of income, with incomes in the richest group going up by a lot compared to the bottom, and in particular from different sources. And that's correlated with actually a forecast in a fall in pensioner poverty. So that's the end of my evidence. I'm just going to give you the key conclusions. The first is, I think, that ELSA is a success in the fact that multiple dimensions of ELSA are now being used for policy analysis. It's not just the financial data, it's not just the health data, it's all of these things simultaneously. The fact that you can measure well-being and health and finance on the same people gives you very different evidence than if you had 3 separate sets of official statistics. Because the links between the factors are as important to policymakers now than the factors themselves. The second lesson is that the longitudinal transitions, when you think about microsimulation, the longitudinal transitions are key, because they can tell you what's going to happen if nothing changes, and they can also what's going to tell you what's happening if you choose to simulate a particular scenario. Finally, this is what JSTAR will be going through the same thing. The good thing about longitudinal data is if you do it right, it gets used more and more over time. Firstly, because you have more generations going through the same ages, so you can make comparisons between the people who were born in the 1940s versus the 1930s. Secondly, even for the existing generations, you have more of a time series, you see more of their life, and as a result, you can model more interesting processes, and you have more observations of change to get effective statistical models. Finally, in Britain, our government never stops changing things. Every year we get a new policy, and often a totally different policy than previously. We have policies that are renaming things, that are changing, removing, and of course in this area you're always going to have opportunities for more evidence because you always need to know more. And if you couple that with the idea that we're adding more areas to the survey, then I think what you have is a possibility of more and more effective policy use over time. Thank you.